Good afternoon and welcome to today's webinar on strategies to improve early recognition of pregnancy-associated cardiomyopathy. My name is Elizabeth Breidenbach on behalf of NACHC. Thank you so much for joining us. I would like to review a few housekeeping announcements before we get started. First things first, here's our lovely online recording disclaimer letting you know that today for this event, the next 60 minutes, this event will be recorded. Content shared today is of the viewpoint of today's presenters and may not fully reflect the opinions of NACHC. You have joined this online event by either physically calling in or using computer audio, either option completely fine. Video and audio for yourself. You should be able to hear my voice, should be able to see slides in the front of your screen, but for all of our attendees out there, your audio have been disabled, your video has been disabled. This is really just to avoid any sort of background noise interference. Q&A, thank you to those submitted questions in advance during registration. We appreciate that and have that in our back pocket for today's Q&A session later on today after we go through today's slides. But for folks that are out there, if you have any comments, questions, or concerns throughout today's event, we ask you to place that into the Q&A box. Simply type your question into that box. You can choose to submit that anonymously if you want. Actually, for participants that are out there, if you see a question that has been asked, there's like a little, I call it an emoji or a thumbs up that you can click on next to that person's question that kind of raises the priority for us on our end as a question that you'd like for us to answer live. We will try to answer as many questions in the time allotted, but if for some odd reason we cannot answer your question live, we'll make an attempt after the event has been completed. Friendly reminders that today's event is being recorded. Your audio and our video have been disabled by myself. This is really to avoid any sort of background noise interference. Q&A box is open and will be open for the duration of this event. And then at the end of today's session, we will have a one poll question for you to let us know how today's event was. And then we'll have a 5-question survey after the fact that we'll send out to participants. And that kind of lets us know from a holistic view. And it is anonymous, letting us know how you felt this 60-minute session was for you today. At this moment, I'd like to turn it over to our fantastic facilitator and moderator extraordinaire, Wanda. The floor is yours.
Thank you. So they were quiet until I started talking. My name is Dr. Wanda Montalvo. I'm the Director of Evidence-Based and Integration Strategy at NACHC. It's a real pleasure to welcome you and introduce our panelists today. First up is Dr. Lisa Hollier, who is the Senior Medical Advisor on the Maternal Mortality Prevention Team in the Division of Reproductive Health at the Center for Disease Control and Prevention. She's received her doctorate in medicine and a master's of public health from Tulane University. She completed her residency in OBGYN at Baylor University Medical Center and a fellowship in maternal fetal medicine at the University of Texas Southwestern, both in Dallas. Dr. Hollier is past president of the American College of OBGYN, and she remains active in clinical care, seeing patients every Monday at a large federally qualified health center in Southwest Houston. So she understands our world and she understands our challenges very well. Our next speaker is so honored to have her here as well. Dr. Catherine Lindley is an associate professor of medicine and associate professor of OB/GYN at Vanderbilt University Medical Center, where she is the Samuel S. Riven Director of Vanderbilt University Women's Health Center. She's clinical investigator specializing in cardio-obstetrics. She is the immediate past chair of the Cardiovascular Disease and Women Committee of the Women's Committee of the American College of Cardiology and chair-elect of the ACC Reproductive Health and Cardio-Obstetrics section. Her clinical and research efforts aim to develop multidisciplinary solutions to reducing short and long-term cardiovascular complications of pregnancy in women with congenital and acquired heart disease. So happy to welcome you all today. Next slide. Very quickly, can you go back one, Elizabeth, to the NACHC? I just wanted to set the tone for folks that may or may not be familiar with NACHC, with the overall number of people that we serve across the country is over 31.5 million. Our health centers are patient governed, and the board is very much engaged and part of the vision for our communities, very diverse. We serve patients across the lifespan. And last year, we served over 550,000 women that were pregnant in our health centers across the country. Next slide. Very quickly, NACHC has been involved with CDC on a maternal mortality project and working with perinatal quality collaboratives in 2 states, Illinois and Pennsylvania. I just wanted to point to that. I think understanding the landscape of health centers is in this space is really important, but a very great key takeaway from health centers in this project was learning more about what the maternal mortality review findings and recommendations are in their state, and the opportunities there are to engage with perinatal quality collaborative efforts in their state to help address and avert pregnancy-related deaths. Next slide. Today, part of the project, we conducted interviews with health centers, site visits, a bi-state meeting with key stakeholders from Illinois and Florida, and really explored what it is that health centers are doing in this space. And some of the things that we'll learn today really came up in the discussions with health centers on the level of risk that they're dealing with patients in their communities, a lot of obesity, a lot of hypertension, preeclampsia, and other things. And I think this topic today is extremely relevant to our conversation. Next slide. This is just a photo of all the people that were involved in this project. And I think we listened to the front line using a human-centered approach and how we're trying to tackle these issues. And that a lot of the solutions and ideas and handouts and how we can make this better is really by engaging with health centers and working with partners like CDC, the MMRCs and PQCs in our states, and very hopeful about the next phase of this work moving forward. Next slide, please. I think the other, just for level setting, is that some of the things that we understand from health centers and challenges in this space is, issues of social drivers, a main one being transportation and food security, data collection. Really important to understand what is the role of health centers in the state and around prenatal and postpartum care, and also what are the resources that partners bring to the table, and leveraging the expertise of MMRCs and PQCs in their state. And I think a real big key takeaway from the work we've done is that health centers, clinicians, everyone on the care team, once aware of what's going on in their state, want to be at the table, be part of the solution, and also to learn from the research and those clinicians in the field that are leading expert research in the space so that we can do better. Next slide, please. And one of the bigger things I think from this work, and this is based on the MMRC care cascade, the health centers hold a lot of promise, especially when it comes to the prenatal, postpartum, early part of care and primary care, and being able to identify women at risk. And that's why today's webinar is so important. Next slide, please. And these are just resources that everyone will receive from the slides, and just, putting it up there ahead so that you guys are aware that we have a lot of resources, and our goal is to help prepare you guys for next steps and help answer questions. Next slide, please. That's that. I'm going to hand it over to Dr. Hollier.
Thank you so much, Wanda. I'm going to take just a few minutes to provide you with some background information about maternal mortality and why the topic of cardiomyopathy is so important. And I'm so excited to be here today with Dr. Lindley. She is an amazing cardiologist, and she's a super terrific presenter. So I'm going to try to zip through this information. Next slide. I have no potential conflicts of interest to disclose. We will be putting links to the data that I'll present to you into the chat so that you can access the data later. Next slide. CDC's Division of Reproductive Health has 2 surveillance programs for pregnancy-related mortality, PMSS and MMRCs. I'll start with the PMSS data, and then we'll transition to MMRC data. CDC initiated national surveillance of pregnancy-related deaths in 1986 to provide more clinical information to fill data gaps about the causes of maternal mortality. The first year of data reporting was 1987. A pregnancy-related death is a death that occurs during pregnancy or within a year after the pregnancy from any cause related to or aggravated by the pregnancy. PMSS has national participation, consistent information available, and consistent coding over long time periods and across jurisdictions. And so we use PMSS to tell the story of disparities. Next slide. Next slide. From 2019 to 2020, the pregnancy-related mortality ratio, or the number of pregnancy-related deaths per 100,000 live births, increased from 17.6 to 24.9. In the next two slides, I'll show you race and ethnicity and rurality graphs with 2017 to 2019 and 2020 added so that you can see the impact of the COVID pandemic. Next slide. This graph shows the considerable racial and ethnic disparities in pregnancy-related mortality in the United States for 2017 to 2019 in blue and for 2020 in gray. During 2020, the pregnancy-related mortality ratios were 63.4 deaths per 100,000 live births among non-Hispanic Native American or Alaska Native persons, 55.9 among non-Hispanic Black persons, and 22.6 among Hispanic persons. Next slide. This graph shows the pregnancy-related mortality ratios by urban and rural classifications. The pregnancy-related mortality ratio increased in 2020 among all urban-rural classifications, and the highest pregnancy-related mortality ratio persisted among people residing in the most rural classification. Next slide. Maternal Mortality Review Committees, or MMRCs for short, seek to provide a deeper understanding of maternal mortality through understanding the contributors to deaths and developing and prioritizing recommendations for prevention. MMRCs use vital records just as PMSS does, but in addition, they use medical records, social service records, mental health records, and in some cases, informant interviews. MMRCs are multidisciplinary committees, including representation of diverse expertise to maximize the broad array of data sources that are available. With this, MMRCs can increase our understanding of both the medical and non-medical contributors to death and identify specific prevention opportunities. Next slide. MMRCs in 38 states contributed data on 525 pregnancy-related deaths that occurred in 2020 among their residents. Next slide. Next slide. It's important to note that 47% of pregnancy-related deaths occurred 1 week to 1 year after the end of pregnancy. Next slide. These are the most frequent underlying causes among the pregnancy-related deaths. The 11 most frequent causes of pregnancy-related death are shown on this slide, but more than 80% of pregnancy-related deaths were related to the top 6 categories. Mental health conditions, which were the most frequent cause of pregnancy-related deaths. Cardiovascular conditions were next, and you can see in the dark purple that cardiomyopathy accounted for 6.8% of these deaths. Infection is next, and COVID accounted for 10.6%. Hemorrhage is next, 11%, embolism, and then hypertensive disorders of pregnancy at 7%. Next slide. To identify opportunities for prevention among disproportionately impacted populations, it's important to look at the underlying causes by race and ethnicity. The next several slides present this data. Next slide. Among non-Hispanic Black persons, 23% of the pregnancy-related deaths were cardiovascular conditions, the most frequent underlying cause of death. 7.9% of these were due to cardiomyopathy. Infection was second. Next slide. Among Hispanic persons, the most frequent underlying cause of pregnancy-related death was infection with COVID-19, which accounted for 28.7% of pregnancy-related deaths. Next slide. Among non-Hispanic Asian Americans, amniotic fluid embolism was the most frequent underlying cause of death. Next slide. And among non-Hispanic white persons, mental health conditions were the most frequent underlying cause of pregnancy-related death, followed by cardiovascular conditions. And again, cardiomyopathy accounted for 6.5% of the pregnancy-related deaths. Next slide. A preventable death is defined as a death with at least some chance of the death being averted by one or more reasonable changes to the patient and family, provider, facility, systems, or community factors. Among the pregnancy-related deaths, 84% were determined to be preventable. 84%. Next slide. Let's take a deeper dive into pregnancy-related deaths from cardiovascular conditions. Next slide. The combined category accounted for 21% of the pregnancy-related deaths in 2017 to 2019. That was 210 pregnancy-related deaths due to cardiovascular conditions in that time period. 60% were due to other cardiovascular conditions, and 40% were due to cardiomyopathy. Next slide. More than half of the cardiomyopathy deaths were classified as peripartum or postpartum cardiomyopathy. Next slide. This slide shows the distribution of the other cardiovascular conditions deaths. Vascular aneurysm or dissection, which includes aortic dissection, was the most frequent subcategory. Next slide. As we look specifically at the cardiomyopathy deaths, 53% occurred more than 43 days to 1 year after the end of pregnancy. Next slide. And 77% of the cardiomyopathy deaths were determined to be preventable. Next slide. ACOG has developed some amazing resource materials, including algorithms for the diagnosis and treatment of acute hypertension, eclampsia, and cardiovascular disease presenting in non-obstetric settings. Next slide. You can access these materials using this QR code if you'd like, and we're also dropping a link to this website into the chat. Thank you all very much for this opportunity today, and I'll hand it over to Dr. Lindley.
Thank you so much, Dr. Hollier. Okay, so that was really a fantastic introduction to the impact of cardiovascular disease and cardiomyopathy on maternal mortalities in the United States. Now we're going to kind of start with a case and kind of work through how we can think about clinically working to better recognize and prevent these cardiomyopathy deaths. So we're going to start with a case. A 38-year-old G4P3103 Black patient, postpartum day 8 from a vaginal delivery, presents to her primary care physician with complaints of 2 days of dyspnea and cough. She's only taken a prenatal vitamin, and on exam, her blood pressure is 152/98, heart rate 118, respiratory rate 24, oxygen saturation is 93%, and she's afebrile. On exam, it's notable for bilateral expiratory wheezes and 2+ lower extremity edema. So what is the next best step for taking care of this patient? Would we say this is most consistent with atypical pneumonia? We should prescribe albuterol and azithromycin and have her follow up in 1 week? Would we say she's just having some residual swelling from her recent pregnancy, so we should prescribe her 20 milligrams of Lasix for 5 days? Should we say this is an emergency and we should send the patient to the emergency room? Or would we say these are normal postpartum findings and we can just provide her with reassurance? Well, let's think through how we might determine that. I'm going to actually spend a little bit of time kind of breaking down some of these ACOG emergency algorithms that Dr. Hollier mentioned to you just a moment ago to kind of think about how we might be able to apply these to our patient care. Now, these were really intended for non-obstetric emergency room settings. So that includes things like the emergency room or EMS. But I actually think that these are all super applicable to really all settings, including obstetric triage units, primary care physician offices, cardiology offices, really anyone who's interacting with a patient who may be having a pregnancy-related cardiovascular complication. So the first thing we have to think about is to remember to ask the patient if they are pregnant or if they've been pregnant in the last 6 weeks, when we're thinking about the fact that her blood pressure is, There you go, 152/98. So that's an elevated blood pressure. And in a normal patient who is not pregnant or postpartum, we would perhaps have them get some more data at home, recheck the pressure, and consider starting some medication. But for a patient who is pregnant or recently pregnant, particularly in the last 6 weeks postpartum, we need to recognize that hypertension is really an emergency, a cardiovascular emergency. So when patients are in that time frame and they show up with a blood pressure of more than 140/90, it's actually important that this be taken very seriously and urgently and have their blood pressure monitored every 15 minutes for up to 4 hours to assess for resolution or progression. We need to assess for signs or symptoms of cardiovascular complications or preeclampsia, and we need to think about obtaining labs. So what are those signs and symptoms we need to think of? Well, there are several that would be concerning for preeclampsia, including headache, visual disturbances, epigastric pain, oliguria, and importantly, shortness of breath or evidence of pulmonary edema, which our patient is presenting with. And so it's important for us to think about considering some additional labs that can help us determine whether or not this patient might have postpartum preeclampsia. It's important to recognize that postpartum preeclampsia accounts for probably up to about 10% of all cases of preeclampsia. And so just because the patient has delivered the baby, it doesn't necessarily indicate that they're out of the woods in terms of hypertensive complications of pregnancy. We also know that people with hypertension or at risk for hypertension are likely to have an increase in their blood pressure in the first week postpartum, peaking around 8 days after delivery. And so patients who may have a risk for increasing hypertension after delivery need to be followed really closely. This rise in blood pressure actually correlates very nicely with the highest risk time for intracranial hemorrhage, which is typically related to hypertensive complications. So ACOG actually several years ago released a nice committee opinion in thinking about how we should sort of reimagine postpartum care. Rather than seeing our patients at 6 weeks postpartum, we should really think about doing a blood pressure check in all patients between days 3 and 10 postpartum, so we can catch these rising blood pressures in that first week after delivery and identify any potential obstetric emergencies. And they also recommend that patients who are high risk for postpartum complications actually have an in-person follow-up appointment with their provider within 1 to 3 weeks after delivery. Now, this can be challenging. It's challenging for the most well-to-do and well-supported woman who's just had a baby to get to a doctor's appointment for a blood pressure check a week after delivery with a newborn. However, it's particularly challenging for patients who have social barriers to obtaining that care. That might be lack of childcare, lack of transportation, living long distances from an obstetric or even primary care provider. And so it's important that we really think about some novel ways that we can reach out to these patients in the early postpartum period. I think an important way to do that is to think about delivering care by telehealth, as well as thinking about using remote blood pressure monitoring to help monitor postpartum blood pressures. This very nice study by Dr. Hirschberg and colleagues identified that doing a remote blood pressure assessment postpartum not only increased postpartum blood pressure assessment for all patients, but it also substantially closed the gap in disparities for Black versus non-Black patients. And although I'm not aware that this has specifically been studied in rural communities, as you can see on the right, there are many communities who are in that Black or royal blue color who live in rural counties who have no access to obstetric care. So I think that this is really an ideal way to reach those patients who live geographically far from a medical center as well. So for this case, we should recognize that this is an emergency and we should send the patient to the emergency room. She has an elevated blood pressure and symptoms of dyspnea, and so this needs to be evaluated immediately. So the patient presents to the emergency room where her blood pressure is 163/105, heart rate is 122, respirations 28, oxygen saturation 93%, and she remains afebrile. She undergoes an EKG, which shows sinus tachycardia, and a chest X-ray, which shows bilateral airspace opacities and small bilateral pleural effusions. Her labs reveal anemia with low normal platelets, a sodium that's reduced at 131, and a creatinine that's 1.0. So what's the next best step for this patient? She has an abnormal chest x-ray and some abnormal vital signs. Would we now say this is consistent with atypical pneumonia, prescribe albuterol and azithromycin, and follow up with primary care in 1 week? Would we say this is an emergency and we need to consult OBGYN and cardiology and obtain additional information? Would we again say this is residual swelling from normal for recent pregnancy and prescribe Lasix? Or do we say these are normal postpartum findings and provide reassurance and discharge home? Well, when we're thinking about management of hypertension in a pregnant or postpartum patient, it's important for us to really be able to stratify that based on the severity of the hypertension. And for this patient, she has a blood pressure that's over 160 systolic or 110 diastolic, which automatically puts her into the range of preeclampsia with severe features. Importantly, she also has symptoms consistent with end organ damage, which is pulmonary edema. So we would consider that this patient has preeclampsia with severe features, and it's really an absolute obstetric emergency to treat this immediately. So these patients, even if their labs are normal, if they have a blood pressure elevated this high, need to immediately have their blood pressure confirmed and treated. And there are several different steps that are important in treating this, but it includes serial blood pressure monitoring, having an obstetrician evaluate the patient, and if there's no obstetrician available, considering transferring that patient to a facility that has an obstetrician. And then we oftentimes will also evaluate for other end organ damage and consider initiation of magnesium sulfate. Now, importantly, not only does this patient have elevated blood pressures, but she also has other evidence of cardiovascular disease. Importantly, she's short of breath, she has an abnormal chest x-ray, and she has quite abnormal vital signs. Now, oftentimes we wouldn't think of a young patient in their 30s or 20s, 30s, or 40s at being at particularly high risk for cardiovascular disease. So a lot of times we kind of overlook these symptoms that they may be having. However, we really need to look at it through a different lens when we have a patient who's pregnant or recently pregnant. So once again, when we're evaluating a younger patient who has these conditions that or symptoms that could be consistent with the cardiovascular condition, we need to be sure to identify whether or not the patient has been pregnant in the last 12 months or is currently pregnant, because it really opens up a whole new can of worms in terms of what diagnoses might be plausible. There's some particular red flags for cardiovascular disease that we need to be thinking about in these patients. And our patient has many of these symptoms, including shortness of breath, resting heart rate above 120, resting systolic blood pressure above 160, respiratory rate above 25, reduced oxygen saturation, and wheezing on exam. We also know that there are many different chief complaints that these patients might present with, which might oftentimes be unrecognized as being due to cardiovascular conditions because they're pretty common in pregnant patients. So that includes dyspnea, edema, and importantly, a cough, which outside of the setting of other symptoms concerning for a respiratory infection should really make you think about whether or not this patient might have pulmonary edema. And importantly, on exam, our patient also had peripheral edema. So when we have a patient that has some of these red flags or chief complaints, we really need to think about cardiovascular conditions and our differential diagnosis. And for this patient with these symptoms that could be consistent with heart failure, we need to be thinking about peripartum cardiomyopathy or other forms of congestive heart failure. I know that there's often a tendency for us when we have patients who are put high risk or maybe not high risk, once they deliver the baby, everyone sort of breathes a sigh of relief and feels like, great, we've done it. We have a healthy baby and a healthy mom. The hard work is over. But it's important to realize that we're not out of the weeds once the mom has delivered the baby. And in fact, this is the highest risk time for cardiovascular complications related to pregnancy. There's a variety of reasons for this, but it includes the fact that in the early postpartum period, cardiac output begins to decline and systemic vascular resistance and blood pressure start to go up. And these are definitely things that can trigger heart failure in patients who are predisposed for it. And so it shouldn't be surprising to us then that in that first 2 weeks after delivery are the most common times for patients to present with peripartum cardiomyopathy. It's also important to recognize, though, that patients may present with heart failure related to other causes earlier on in the pregnancy. Oftentimes, patients may have cardiovascular disease that's been unrecognized or untreated for a long period of time that may begin to manifest once a patient undergoes the hemodynamic stresses of pregnancy. We know that the demands for cardiac output begin to rise quite early in pregnancy and peak by about 28 to 32 weeks of gestation. So patients who have underlying heart failure related to pulmonary hypertension, congenital heart disease, hypertrophic cardiomyopathy, genetic cardiomyopathies, may begin to manifest those symptoms as they get into the late second to early third trimester. As I mentioned before, it can be very difficult to identify pregnancy-associated heart failure because so many of these symptoms can be seen, or similar symptoms can be seen in a normal pregnant patient. But it's important for us to take all of these complaints really seriously and have a low threshold for evaluating whether or not there could be an underlying cardiac etiology. There we go. So kind of going back to our algorithm, if we have a patient who has any of these signs or symptoms that would be concerning for a cardiovascular condition, not only should we get an EKG and a chest x-ray, but we also need to think about obtaining a BNP level and a troponin. Now, BNP and troponin can be particularly useful tools in pregnant and postpartum patients, as they should be normal in all of these patients. And while we don't recommend testing them routinely in patients, we do recommend testing them if we have a patient who has concern for heart failure or ischemic heart disease, at index diagnosis of peripartum cardiomyopathy, or patients who we know have underlying structural conditions such as heart failure, valvular heart disease, that may be at risk for progressing to heart failure symptoms later on in pregnancy. Now, after performing this initial diagnosis with blood tests, chest x-ray, and EKG, we need to think about what to do with those results. So if the patient has any abnormalities in these results, it's very important that we proceed next to an echocardiogram. I think oftentimes people see an elevated BNP in the setting of preeclampsia, and their thought is, oh, it's, quote, just preeclampsia, and we don't need to do any further evaluation. However, it's really not recommended by experts in the field to sort of downplay the importance of elevated BNP or troponin or abnormal chest x-rays in patients who are presenting with dyspnea. So it's important to get an echocardiogram, and if that's not available at your facility, we would recommend that the patient be transferred to a facility where they can obtain that. And it's also important to consult both cardiology and obstetrics or maternal fetal medicine whenever possible, so that we can really do a little bit deeper dive into what cardiovascular or pregnancy-related conditions may be affecting the patient. Lastly, when we think about initiating treatment for these patients, I know that we all appropriately and importantly think about what is the safety of utilization of cardiovascular medications in our pregnant and postpartum patients, and as we should. Although it is important to remember that when a patient is presenting with a life-threatening emergency, we should never withhold any cardiovascular diagnostic or treatment because of concern about pregnancy or breastfeeding. I always just sort of try to keep in mind that if we keep mom healthy and alive, that's also going to result in the best possible outcome for the baby. So what is the next best step for this patient? Well, the answer is that this is an emergency. She's having abnormal imaging, abnormal vital signs consistent with severe preeclampsia and tachycardia, and we really need to consult OBGYN and cardiology and obtain some additional information with some additional laboratories. So this patient underwent some additional lab assessment, which revealed an NT-proBNP of 1295. She had a negative troponin. Her AST and ALT were both elevated. She had a normal TSH, and she underwent an echocardiogram, which showed an LV ejection fraction of 38%. And just for reference, normal is between 55 and 70. So ultimately, I would diagnose this patient with preeclampsia with severe features based on her elevated blood pressures, her end organ damage symptoms, and her abnormal laboratory values, as well as peripartum cardiomyopathy, as she's in the early postpartum period with evidence of new onset heart failure. Now, again, kind of going back to my previous comments, it's important to recognize the relationship between preeclampsia and peripartum cardiomyopathy. Just because a patient has peripartum or preeclampsia, we should not assume that the patient does not have peripartum cardiomyopathy. In fact, we know that preeclampsia is a major risk factor for developing LV dysfunction and peripartum cardiomyopathy. And about 20% of patients who are diagnosed with peripartum cardiomyopathy also carry a diagnosis of preeclampsia. So we should actually be very cognizant of this risk. We have a patient presenting with hypertension. Now, peripartum cardiomyopathy has a specific diagnosis. It's a diagnosis of exclusion, and it really needs to develop within the last month of pregnancy or within the first 5 months after delivery. Patients are required to have a reduction in their LV systolic function, which is usually assessed by an ejection fraction of less than 45%. And they can't have other pre-existing heart conditions or other identifiable causes of heart failure. So there are a variety of other important causes of heart failure that we need to be thinking about in our patients who might be presenting with heart failure around the time of delivery. That can include sepsis-mediated cardiomyopathy, which is often seen in patients who are presenting with heart failure in the setting of chorioamnionitis or a wound infection or pelvic abscess. However, the hemodynamics of this condition are very different. They have low filling pressures and high cardiac output despite a low EF, and it always resolves within about 2 weeks. We also need to always consider pregnancy-associated thyroid disease. We know that postpartum thyroiditis can occur in up to 5% of pregnancies, and the thyrotoxicosis that can result from this can lead to severe tachycardia and LV dysfunction. So it's important to check a TSH when we're evaluating cardiomyopathy in a postpartum patient. Takotsubo cardiomyopathy is also known as broken heart syndrome or stress-mediated cardiomyopathy. This is not a common cause of heart failure in pregnant or postpartum patients, but we certainly do see it more frequently when patients have had a cesarean delivery or other major stressors. And it's diagnosed by a very specific pattern on the echocardiogram. It's also increasingly important that we think about the impact of diastolic heart failure in our pregnant and postpartum patients. Over the last several decades, we've seen an increasing rate of diastolic heart failure or heart failure with preserved ejection fraction occurring usually in the early postpartum period. This is most frequently, but not always, associated with hypertensive disorders of pregnancy. And whether it occurs before delivery, at delivery, or postpartum, you can see here that hypertensive disorders of pregnancy substantially increase the risk of this developing. While in the past, many have thought that pulmonary edema in the setting of a normal ejection fraction and hypertension is just related to sort of leaky vessels in the lungs, increased data over the last decade has really suggested that this is likely related to acute diastolic dysfunction, related to probably some microvascular ischemia of the heart, related to the endothelial dysfunction associated with hypertensive disorders of pregnancy. So we're sort of increasingly beginning to recognize that there's not just normal or peripartum cardiomyopathy, but there's probably really a spectrum of severity of heart failure that presents in postpartum or late pregnancy patients that are probably related to a variety of genetic and environmental factors that may lead to sort of a similar clinical phenotype with different underlying etiologies. So when we're thinking about peripartum cardiomyopathy, who should we be most keyed into? Well, there are certain risk factors that we know increase the likelihood of peripartum cardiomyopathy, including twin pregnancy, high parity or high gravity, which our patient had, extremes of reproductive age, which our patient had, hypertension and African ancestry are major contributors. And then lastly, as I mentioned, preeclampsia is significantly thought to be a major contributor as well. The good news, as you heard before from Dr. Hollier, is that peripartum cardiomyopathy deaths can be prevented. When we look at data from our MMRCs assessing why patients died related to their pregnancy, we see a relatively even distribution between patient-related factors, provider-related factors, and systems of care factors. Now, the patient-related factors include things like failure of the patient to recognize their symptoms in chronic conditions such as obesity and hypertension. But I want to be the first to point out that I think these patient-related factors are very much dependent on provider and system of care-related factors. Because of course, if we don't educate our patients that they're at risk and what those symptoms would be, they're not going to recognize them. And if they have difficulty accessing longitudinal care, they're going to be more likely to have untreated chronic medical conditions. Provider-related factors primarily relate to failure to recognize the disease and therefore providing ineffective treatment and failing to refer to the appropriate subspecialist. While everyone who finished medical training knows about preeclampsia, knows about peripartum cardiomyopathy, most of us don't see it that often, and so we just don't think about it. And we think about more common conditions like asthma or pneumonia. And so failing to recognize the appropriate condition and provide the appropriate treatment or refer to the appropriate providers leads to delay in care and poor outcomes. And then finally, systems of care-related factors are primarily related to lack of communication between specialists and barriers to coordination of care. So I think that this ACOG-OB emergencies set of algorithms is very useful for helping us have a framework about how we can think about better recognizing emergencies in our patients, even outside of the labor and delivery setting. And it really all begins with asking your patient, are you pregnant or have you been pregnant in the last 12 months? And if the answer is yes, we need to really reframe our approach to the patient to be thinking about common conditions, and it's particularly cardiovascular conditions that may be presenting in this otherwise young and perhaps healthy patient. And then once we've identified those disorders, it's really valuable to refer back to those algorithms and protocols to help us appropriately and promptly treat the patient and triage them to the right providers. Dr. Hollier mentioned this before, and I will just mention it again. These tools and resources are all readily available for free. So I highly recommend you look them up and consider implementing them in your practice. And I just want to close by saying, we all come from different specialties. We're primary care providers, we're OBGYNs, we're nurse midwives, we're cardiologists, we're emergency room providers, but we're really all here to care for our patients. And so we need to really think about how we can coordinate care across specialties to allow, our primary care providers to help provide a lot of the interpregnancy and longitudinal care, but also they might be the most likely ones to first see the patient and recognize the condition. It's important to ask if our patient's pregnant or recently been pregnant so we can think about it through the proper lens. We need to remember to assess for those common causes of maternal mortality that we might otherwise forget because we don't see them so often. And then we really need to ensure early postpartum follow-up for our high-risk patients to make sure we can quickly recognize postpartum hypertension complications and cardiovascular symptoms that may be brewing. So I thank you very much for your attention, and I think that we will all be happy to take some questions now.
Sure. Elizabeth, can you take down that big, I'd just like to see the panel. I think those are
Absolutely. Give me just one second.
second.
There you go.
I have the first question. I think it came through the Q&A. I know we had some before, but it says, how can you be more proactive in detecting cardiomyopathy?
Well, I think that, some of the things I kind of talked about are, number one, make sure you recognize that your patient is pregnant or postpartum. They may not think to tell you that, especially if they're 6 weeks postpartum or 2 months postpartum. And then if so, it always needs to be on your mind. It's a rare condition, but it is life-threatening, and we can't ever afford to miss it once. So I have an extremely low threshold for checking a BNP level on my patients with any symptoms that might be consistent with peripartum cardiomyopathy or other, maybe they have unrecognized congenital heart disease or pulmonary hypertension. Those things will all cause the BNP to be elevated. It's very sensitive. And so if it's positive, I always follow up then with an echocardiogram. And if it's negative, we can feel quite reassured that this is not likely a heart failure related symptom.
Dr. Hollier, anything else to add?
No, Kate did a great job.
And then I think the other, can you discuss the relationship, wait, somebody else, the thing moved. I thought this was a good question. Okay. Can you discuss the role of persistent perinatal and postpartum tachycardia as a sign of cardiac disorder?
Sure, I'm happy to take this, and then I can probably hand it over to Dr. Hollier as well, if she has anything to add. It is a very important potential marker. Now, it is true that usually patients are going to have other signs and symptoms besides just tachycardia. But if a patient is in a low output state, the only way they can maintain perfusion of their body is oftentimes by increasing their heart rate. And so persistent tachycardia is something that should make us think about heart failure, and again, have a low threshold for checking a BNP. Now, of course, there are many other things that can cause persistent tachycardia, such as namely infection, pulmonary embolism, and anemia. So those are some of the big common things that we also see. It does certainly it's not a specific thing, but it is relatively sensitive. And so you should evaluate for cardiovascular causes. And if they're not there, then I kind of pass the baton back to my OBGYN colleagues to investigate other potential etiologies.
Thanks, Dr. Lindley. And I think it's really important for us as that frontline person, when we see tachycardia, we need to evaluate it. It's a really important step for us to take on the front line and do the additional evaluation that's necessary.
One of the questions came in that they have patients with very high PNP. At what level are you concerned about it being cardiomyopathy?
So I would say, I sort of joke, if it's yellow in the chart, we should be concerned. If it's above the upper limits of normal. And it is absolutely true that like higher levels are more specific for heart failure, more likely to be reflective of cardiomyopathy. But I've definitely had patients with a BNP of 200 and they had an ejection fraction of 35%. And I've had patients with a BNP of 4,000 and they just had diastolic heart failure related to their preeclampsia. So I think we can't be confident about what their heart function is based on the degree of elevation, but it should be normal. And so if it's elevated, it requires further evaluation. And the last thing I'll say about it is it can be affected by other cardiometabolic conditions. So BNP is metabolized by fat. And so very obese people may have a falsely low level. And so if I have very high concern despite a normal BNP, I will still follow up with an echocardiogram. And then BNP is cleared by the kidneys and it's released by the brain. So somebody having a stroke or somebody with end-stage renal disease, those patients may have a falsely high level. So you have to kind of take it in context.
So it kind of goes with this question, is checking the PNP in the outpatient setting or only when patient is inpatient?
I check it in both. So I actually follow this serial in my patients who are at high risk for developing heart failure during pregnancy. But I also check it relatively regularly. Let's say I have a patient who's 36 weeks and coming to see me with sinus tachycardia. The most likely thing is she's just really pregnant and it's normal pregnancy physiology. But when she's that far along in pregnancy, we have to consider the possibility of peripartum cardiomyopathy. So I'll still usually check it. And if it's normal, I feel reassured and don't follow up with an echocardiogram. And if it's high, then I would immediately follow with an echocardiogram.
Anything else, Lisa, to add? No? Okay. One of the questions that I think is really relevant for a lot of our health centers, because there's, a very interprofessional approach to prenatal postpartum care, question is, what is the role of the non-OB PCP provider in this space?
Dr. Hollier, would you like to answer this or would you like me to, or whatever you prefer?
I think there's a tremendous role for all of us to play. As a frontline provider myself in clinic, I think we're sort of that first touch with the patient. And so we have to be really alert for the signs, for the symptoms that Dr. Lindley has described today. So whether you're a OB-GYN physician, a maternal fetal medicine specialist, a midwife, a nurse practitioner, a family physician. All of us really need to be aware of these signs and symptoms, and we need to act on them. And when our patients come into us with concerns, with feelings of shortness of breath, really feeling like something is wrong, we need to be listening to what they're saying. Dr. Lindley?
Yeah, I agree completely. All of us, we're all on the same team, and all specialties miss these problems. So I think it's really important that we communicate with one another, that we develop a network of patient care, and realize that as the patient's family practice physician or primary care nurse practitioner, you might be the first one to recognize this. And so having a good understanding of pregnancy risks and complications is super important for everyone.
One more I'm going to add to the list, because a lot of health centers have co-located OB and pediatrics, that our pediatricians sometimes might be the first one to see, the birthing person come back for that visit. They may skip. This is the other thing, right? The concern that people may skip that postpartum follow-up, and sometimes they show up with their newborn, and that's an opportunity. So every single, as you have stated, every single care team member plays such an important role and have awareness around this, and the importance of getting people back. Another question that came up from the field was, how can we better understand cardiovascular conditions and pregnant and postpartum people in order to reduce the disparities overall?
Wanda, I think one of the ways that we can all get a better understanding of cardiovascular conditions and the interventions that we can put into place to make change happen is looking at the Maternal Mortality Review Committee reports from your state or your jurisdiction. It's a great source of information. It'll provide not only the causes that I talked about today, but also provide the contributing factors and then the specific recommendations to address the contributing factors to the deaths that were identified by the local Maternal Mortality Review Committee. So I think those MMRC reports are a really great source of information so that you can partner with other groups like perinatal quality collaboratives to implement solutions.
I agree, just because they've been exposed to some of the incredible people that work on MMRC and PQC. I think health centers should seek out the expertise that's available to them in their own backyard. They would love to connect with FQHCs. I've heard that over and over again. I think our health centers also have a lot of good insight and expertise to what is going on in their own county and backyard and community. So, tap into that, be able to bring this information, elevate everyone in your staff to be aware of these things. And because I think we universally share a desire to improve and obtain the best outcomes for the patients we serve, right? That's like universal to all of us. Let's see.
Wanda, while you're looking, I just want to acknowledge all of Dr. Lindley's service on maternal mortality review committees in multiple states. So thank you, Dr. Lindley.
Thank you.
It's
Some of the best work that I do. It's hard, but it's important, and it is a real opportunity to actually make a measurable difference.
So the next question is a little longer. Since there are probably many women who were not monitored postpartum and now have cardiomyopathy for many years, what is their prognosis?
Yeah, so that's a great question. If you gave me the whole day, we could talk about all of these things, but I didn't really talk about treatment or prognosis because of time, but I'm happy to address this. It's true that many women will fall out of care after their initial postpartum period. As you're all well aware, many of our patients lose healthcare coverage postpartum, and fortunately, almost all states have now enacted extended postpartum Medicaid coverage. So many of these patients can at least get care for a year, but we're still perhaps back to the drawing board after that. The good news is that many patients with peripartum cardiomyopathy will recover. There are several prognostic factors that go into that. So how sick they are to begin, how low their ejection fraction is, if they have right ventricular dysfunction, And we know that Black patients tend to be less likely to have recovery. But all in all, really about 2/3 of patients are expected to have recovery or at least partial recovery, and only up to about 1/3 of patients aren't expected to have substantial recovery. And that's really only the patients who were very, very sick to begin. It is extremely important that we talk to these patients about contraception, and I highly advocate for long-acting reversible contraceptives in these patients. They are not only safe, but they are extremely effective, and it really allows the patient to be in control of if and when they're going to have a future pregnancy. If they do have complete recovery of their heart function, then it still remains high risk for future pregnancies, but it's not necessarily an absolute contraindication. However, if people have residual dysfunction of their heart, we do not recommend future pregnancies because of about a 25% risk of mortality. So what I think is really helpful is to make sure our patients are on highly effective contraception. They get as much continuity of care as they can, and they receive a lot of education about it so that they can really make an informed decision in the future about whether or not they are wanting to take the risk of subsequent pregnancies.
As you were sharing, one of the things that came to mind is that, a lot of the things that we talk about when it coverage and Medicaid and everything else, that some of these things, even scope of practice, right, and in certain states fall into these arenas of barriers that are really policy. And I just put in the chat, we are having a listening session at NAC being hosted by my colleague Bailey. Just listening to the field would have focused on understanding what are the ongoing, barriers related to maternal health services that health centers are facing. So I encourage folks to register for that. We also have an upcoming webinar, I think it's next week, hosted by our Million Hearts. That's going to focus on self-monitoring blood pressure and hypertension in pregnancy, and a lot of tips there as well. And, I'm welcome to have you come back and go a little bit further into some of the treatment and details that you mentioned earlier. I think the field is hungry, and what we have is, more and more, I think, maternal health deserts where health centers are in the front line, taking care and being able to identify the high-risk patients. A lot of the things you highlighted are, it comes through our door every single day, patients at risk with all the things. Any last words? I will default to my two colleagues for a closeout.
No, I just want to echo everything you said, Dr. Montalvo, that, our community health centers really are essential in identifying and treating these patients. You're more accessible to the patients, whereas related to geography or insurance coverage, et cetera, sometimes referral centers are not. And I think you also know the patients and know the community, and the patients and community have trust in you. And that is really important for helping facilitate patient care and communication, so that we can it's really these highest risk patients who are the ones that are at most risk of getting the disease and dying from it. So your role is really critical.
So,
Just thank you all for all of you who are out there working in community health centers. It's really hard work. I understand that. I do it. But I really do think that we make a tremendous difference in the lives of those we care for.
I am so honored to have had this opportunity to do this with both of you. I so appreciate you. I appreciate all the people who participated today. I promise we will be sending out the recording, all the resources, and please stay tuned, and that we are committed to supporting and moving answers forward together. Thank you so much.